Our hands are extraordinary tools. They allow us to perform the most delicate of tasks, like threading a needle, and the most powerful, like gripping a heavy object. This incredible range of function is made possible by a complex network of structures working in perfect harmony. At the heart of this system are the flexor tendons. These are the strong, cord-like tissues that connect the muscles in our forearms to the bones in our fingers and thumb. Think of them as the sophisticated pulley system of the hand. When you decide to bend your finger, your brain sends a signal to a muscle in your forearm, which then pulls on a specific tendon, causing the finger to curl into your palm. Without healthy flexor tendons, the simple act of making a fist becomes an impossibility. You wouldn't be able to hold a pen to write, grip a steering wheel to drive, or lift a cup of tea to your lips. These tendons are essential for almost every daily activity we perform, from getting dressed in the morning to preparing a meal in the evening. The most frequent cause is what we call a laceration. Imagine someone washing dishes, and a sharp knife slips, cutting the palm of their hand or the inside of their finger. That knife can easily slice through the skin underlying tissues and one or more of the flexor tendons hiding just beneath the surface. Another way these injuries occur is through a crush mechanism. Similarly, some sports injuries can lead to a specific type of tendon damage called an avulsion injury. A classic example is jersey finger, where a rugby player grabs an opponent's jersey and their finger gets caught and pulled back violently, tearing the tendon from its insertion point. A severed tendon cannot heal on its own. Because the tendon is under constant tension from the muscle it is attached to in the forearm, the proximal end will retract, pulling away from the distal end like a snapped rubber band. Without surgical intervention to find those retracted ends and carefully stitch them back together, the finger will lose its ability to bend permanently. Therefore, when a patient presents with a deep cut on the palm side of their hand or finger, you must always have a high index of suspicion for a flexor tendon injury. The patient might not be in a great deal of pain, and the external wound might look deceptively small. If you ask the patient to bend the affected finger and they are unable to, it is a significant red flag. This immediate loss of function is the hallmark of a complete tendon laceration and signals the urgent need for a surgical consultation and repair. To properly treat a flexor tendon injury, you need a basic map of the territory you are working in. Let's simplify the anatomy. In each of your fingers, index, middle, ring, little, you have two flexor tendons. One is called the flexor digitorum superficialis, or FDS for short. This tendon attaches to the middle bone of your finger, the middle phalanx, and is responsible for bending the finger at the middle joint. The other is the flexor digitorum profundus, or FDP. This one runs deeper, passing through a split in the FDS tendon and travels all the way to the tip of your finger, attaching to the distal phalanx. The FDP is what allows you to bend the very end of your finger. Your thumb is a bit different. It is simpler. It only has one long flexor tendon called the flexor pollicis longus, or FPL. This single tendon is responsible for bending both joints of your thumb. These tendons, the FDS, the FDP, and the FPL, all originate from muscles located in your forearm. This is why when you wiggle your fingers, you can see and feel the muscles contracting on the inside of your forearm near your elbow. To make things more complex, these tendons do not just float freely within the fingers, they are housed within a tight, tunnel-like structure called the flexor tendon sheath. This sheath is lined with a synovial membrane that produces a lubricating fluid, much like oil in an engine, allowing the tendons to glide smoothly back and forth with minimal friction. The sheath is held in place by a series of fibrous bands called pulleys. These pulleys are crucial. They act like the eyelets on a fishing rod, holding the tendon close to the bone. Without these pulleys, the tendon would bowstring across the joint when you bend your finger, leading to a significant loss of motion and strength. The location of the injury, often described by a zone system, dictates the surgical approach and the post-operative therapy protocol. An injury within the tight confines of the tendon sheath, often called no man's land, is notoriously difficult to manage because of the high risk of adhesions, where the healing tendon sticks to the surrounding sheath, preventing it from gliding. After a surgeon has meticulously repaired a severed flexor tendon, the healing process begins. This is an incredibly delicate phase. The sutures holding the tendon ends together are very fine, about the thickness of a human hair, and can easily be ruptured. The primary goal of early therapy is to protect this fragile repair from any force or tension that could pull it apart. This is where the dorsal block splint comes in. It is the single most important piece of equipment in the early stages of flexor tendon rehabilitation. It acts as a protective shield. creating a safe and controlled environment for the tendon to begin healing. The dorsal block splint is a custom-made thermoplastic splint worn on the back or dorsal side of the hand and forearm. It positions the wrist in a slightly flexed position, typically around 20 to 30 degrees. The main part of the splint extends up the forearm and across the back of the hand, but it stops before the knuckles, leaving the fingers free. The knuckles or metacarpophalangeal joints are held in a more significant degree of flexion, usually between 50 and 70 degrees, often with a strap or another component of the splint. The purpose of this specific positioning is simple but brilliant. By flexing the wrist and by flexing the MCP joints, the splint puts the flexor tendons on slack. Think of a rope tied between two poles. If you move the poles closer together, the rope becomes loose. This position reduces the passive tension on the tendon repair site, creating a low-stress environment that is optimal for healing. Most importantly, the block part of the splint's name refers to its primary function. It physically blocks the fingers from straightening out completely. This prevents the patient from accidentally stretching and rupturing the delicate repair. The dorsal block splint is usually made and fitted by an occupational therapist within the first few days after surgery, sometimes even on the same day. It's custom molded to the patient's arm using low-temperature thermoplastic. This ensures a perfect, comfortable fit because the patient must wear it continuously for several weeks. The therapist positions the patient's wrist, then the hand in the exact angles the surgeon requires before shaping the warm, pliable plastic. Straps are then added to secure the splint to the forearm and the hand. Key point: the splint must be worn 24 hours a day and 7 days a week. This is non-negotiable in early healing. It only comes off for supervised therapy sessions with the OT. Patients must be educated on how critical this is. Even one careless moment, reaching to catch a falling object or pushing up from a chair with the injured hand, can cause a catastrophic re-rupture. That can mean returning to the operating theater and restarting the rehab from day one. Education is paramount. Explain the why behind every rule. Show the patient how the splint works. Demonstrate how straightening the fingers puts tension on the repair. Use analogies like freshly glued pottery that must stay still. Teach splint and skin care. Check regularly for red marks and pressure sores, especially over bony areas. Clean the splint with a damp cloth and soap, but keep the hand clean and dry to avoid infection. As healing progresses, about 4 to 6 weeks, the therapist will gradually adjust the splint. The degree of wrist flexion and knuckle flexion is slowly reduced, allowing more movement as strength returns. Follow the therapy protocol timeline. The dorsal block splint isn't one-size-fits-all or a set-it-and-forget-it device. It's a dynamic tool therapists modify week by week to guide the tendon safely toward full recovery. Once the repaired tendon is protected within the dorsal block splint, the next crucial step begins: early mobilization. For many years, the standard after repair was complete immobilization in a cast for weeks. Research and clinical experience have shown this causes significant problems. When a healing tendon is kept completely still, it tends to get stuck to the surrounding tissues and the flexor sheath. This leads to dense scar tissue, adhesions, which can permanently limit tendon glide. The finger becomes stiff. The functional outcome is often poor. Modern rehab protocols emphasize early passive mobilization. The key word: passive. The patient does not use their own muscle power to bend the injured finger. Movement is generated by an external force, most commonly, the patient's other uninjured hand. The goal: gently move the repaired tendon a few millimeters back and forth inside its sheath. This tiny motion discourages adhesions from forming, like running a string through a tube to keep it clear. Early motion also improves synovial fluid nutrition to the tendon, which can improve the speed and quality of healing. It helps maintain passive range of motion in the finger joints, preventing them from becoming stiff and contracted. It also provides a small amount of controlled stress to the healing tendon. Gentle, controlled loading stimulates tendon fibers to align in a stronger, organized way, leading to a more robust repair long-term. This is a delicate balancing act. Movement must be gentle enough to avoid rupturing the fragile repair, yet consistent enough to prevent stiffening scar tissue. You are teaching them to walk a tightrope between too little motion and too much. The specific exercises for early passive mobilization are simple in action but require great care and precision. The most common protocol starts within the first week after surgery. The first exercise is passive flexion. While wearing the dorsal block splint, the patient uses their uninjured hand to slowly and gently bend the fingers of the injured hand, one at a time, all together down towards the palm. They should bend them as far as they will comfortably go, Hold for a few seconds, and then slowly allow them to relax back to the resting position in the splint. This should be repeated about 10 times, several times throughout the day. The second key exercise is active extension to the limit of the splint. This sounds contradictory to the passive mobilization principle, but it is a very specific and safe movement. After passively flexing the fingers down to the palm, the patient is instructed to relax their good hand, then gently try to straighten the injured fingers on their own. They will not be able to straighten them fully because the dorsal block splint will stop them. The goal is simply to actively extend the fingers until they touch the back of the splint. This motion helps the two sets of tendons, flexors and extensors, glide in opposite directions, and is very effective at minimizing adhesions. Safety is the #1 priority during this phase. You must instruct the patient to never, under any circumstances, actively bend their injured finger. They must not try to make a fist using the muscles of their injured arm. This action, called active flexion, would generate far too much force and would almost certainly rupture the repair. All bending must be done passively by the other hand. Furthermore, they must never remove the splint to perform their exercises. The splint is their safety net, and all movements must be performed within its protective boundaries. Consistency is the key to success. These gentle exercises need to be performed diligently every day. It can be helpful to link the exercises to daily routines, every time a commercial comes on the television after brushing their teeth. The path to recovery after a flexor tendon repair is fraught with potential pitfalls. As a therapist, one of your primary roles is to anticipate these common mistakes and educate your patient to avoid them. Perhaps the most frequent and dangerous error is non-compliance with wearing the splint. A patient might take it off because it feels cumbersome, or they might think, just for a second won't hurt. This is a critical misunderstanding. A single unguarded movement, a reflexive reach or stretch, is all it takes to undo the surgeon's work. Some patients become overzealous. They pull too hard during passive flexion, causing pain and potentially gapping or even rupturing the repair. Conversely, others are too fearful and become timid, barely moving the finger at all. Insufficient movement leads to stiffening adhesions. Your job is to find that just right amount of force and motion. Guide the patient's hand with your own to help them feel the correct, gentle tension. Misunderstanding the difference between active and passive flexion is a huge pitfall. Patients may try to bend using their own muscle power. You must repeatedly clarify. Your good hand does all the work of bending the finger. Your injured hand just goes along for the ride. Use clear, simple language and have the patient demonstrate the exercises back to you in the clinic. Finally, a lack of communication can derail rehab. A patient might notice new pain, swelling, or that their finger feels stuck but not mention it until their next appointment a week later. That delay can let a small problem become much bigger. Encourage your patients to call you if they have any concerns. Foster an open, trusting therapeutic relationship where the patient feels comfortable asking questions and reporting changes. As you embark on your career as an occupational therapist, you will find that treating flexor tendon injuries is one of the most challenging yet rewarding areas of practice. It demands a deep understanding of anatomy, biomechanics, tissue healing. It requires precision patience, excellent communication skills. The key takeaway is to always respect the biology of tendon healing. The initial repair is fragile. Your first priority is protection. The dorsal block splint is your most powerful tool in this early phase, creating a safe haven for healing to begin. Remember the delicate balance you must strike, protecting the repair, promoting tendon glide. Early passive mobilization is the method you will use. These gentle, controlled movements prevent debilitating adhesions that can permanently rob a hand of its function. Your role as an educator is paramount. The patient's understanding of the protocol, their diligence in performing exercises at home. You are not just a therapist, coach, guide, source of support. Do not be afraid to seek guidance. Protocols can be complex and are constantly evolving as research emerges. Always follow the hand surgeon's specific instructions. They may prefer different approaches based on the injury type or the suture technique used. Collaborate with senior therapists, ask questions, never stop learning. Each patient will present unique challenges. Your problem-solving and adaptation skills will grow with every hand you treat. Finally, never lose sight of the person attached to the injured hand. A flexor tendon injury can be frightening and life-altering. Patients may be unable to care for their families, engage in hobbies they love. Empathy, encouragement, a positive attitude. These make a world of difference. By mastering flexor tendon rehabilitation principles, you are restoring independence, livelihood, the ability to connect with the world. This is a profound responsibility and an incredible privilege.